And so the first requirement is for the medical records will decrease from 5 years to 3 years in the first patient level eligibility criteria question. So is there evidence that medical records are available for this patient for 5 years or until distant recurrence or death? So it used to be 5 years, and we are now decreasing this criteria to 3 years. The replacement queue will include patients diagnosed in the years 2008 to 2010. So previously, only the patients diagnosed between 2005 and 2008 were included in the study. These changes will take into effect Tuesday, May 30th at 11:59 p.m. Central Standard Time, so that is tonight around midnight. Updated instructions version 2 is on the website and the web form, and it's also on the Cancer Forum, and we will not be mailing this out. So we thank you for asking questions. Many questions relate to, is this patient eligible? What if you can only get some records for a patient but not all the records? Even with the new eligibility change, we need you to get all of the records from the patient's providers. And what if the PCP's office responds but the urologist's office will not respond? This is required for the study to have all of the provider's records. So the key question is, do you feel you are able to record all of the PSAs a patient has had after treatment? So 3 years is required for a patient to be eligible. Once eligible, we ask for 8 years of follow-up. For eligibility criteria, there needs to be evidence that medical records are available for the patient for 3 consecutive years or until distant recurrence or death, whichever is first. For patients who received primary radical prostatectomy, the patient's urologist and primary care physician can be identified. And for patients who received primary radiotherapy, the patient's radiation oncologist and urologist and primary care physician can be identified. The patient has at least one PSA test result within 2 years and after end of primary treatment, and the registrar is confident in capturing the PSA information for 2 years after primary treatment completion. So all 3 of these questions need to be answered yes in order for a patient to be eligible. So for patient eligibility, if any eligibility question is answered no and is submitted, a new patient should automatically be added to the list once the page is refreshed. Please wait at least 2 weeks to hear back from outside offices for the record. If the patient does not have a PCP, then the patient is eligible. If you do not know that the patient has a PCP, or if the patient has a PCP but you are not able to get the records, then this patient is not eligible. A complete record for 3 years is needed for a patient to be eligible. However, it's possible that some patients did not have PSAs every year, and that is okay, and they can still be eligible. Only the questions on the study web form are the required information for the study, and patients receiving care at the VA for prostate cancer or prostate cancer follow-up are not eligible, so please mark those as ineligible. So PSA, we would like you to enter PSAs until the time of distant recurrence or death or until the end of the surveillance period, not at the biochemical recurrence. So please round the results to the nearest tenth, and the registrar should follow the Ford's manual. For example, a PSA of 1.2, the registrar can enter 0, 1, 2, or 12. Numerically, these are identical numbers and will not affect the study or data analysis, except when a patient has a result of less than 0.03 or 0.01 or less than 0.02 or less than some small number. Please enter the result of 0 for this special study. In this sole instance, we differ from the Ford's manual, and the example was given in the instructions to specifically show this. So for testosterone, Testosterone values of less than 20 picograms per deciliter should be entered as 0, and testosterone tests might not be collected for a patient during the surveillance period, and that is okay. It depends on the different clinics. So scans that are clearly not related to prostate cancer or prostate cancer recurrence anywhere in the body do not need to be entered. If you're not sure about whether a scan should be entered, please err on the side of entering. So, for example, if a patient developed a second cancer of the urethra and found lung lesions, and upon biopsy they were from prostate cancer, we would like you to please enter all of the lung scans, biopsies, and treatments since they were from prostate cancer. For recurrence, when the doctor indicates possible recurrence and a treatment starts, this should be considered recurrence. The date of the recurrence should be the date of the doctor's note stating that the patient had a recurrence. The term salvage radiotherapy indicates a recurrence, and after definitive radiation treatment, if cancer is shown on the TUR pathology, please record as a local recurrence. So on the additional clinical information tab, if the pathology report states suspicious for LVI, enter as no. There's no response for suspicious for the study, so please just categorize as no. Please only use the surgical pathology report. If perineural invasion was found on the biopsy report but not the surgical pathology report, please enter no. So all instructions in the special study instructions document are for the special study only, and that includes for version 2 of the special study document, and boards should be used for routine data collection for the NCDB. Specifically, the instructions for coding biochemical recurrence in patients who are never disease-free instructions are different from the Ford's definitions and are only for the special study. Do not update the NCDB with recurrence differences, and we realize this is different from Ford's. If you find a patient has had a recurrence by Ford's definition and that recurrence was not previously recorded in the NCDB, we ask that you please update the patient's NCDB record with that information. So we have created a patient data form, and this has been added to the study website and the Cancer Forum. This can be used to aid in data collection. The instructions document is still the main resource for the study. So if on the web form, if there's any error messages appear while using data links, when logging into the web form, please use a lowercase if there's a capital in the password. And if there's any errors on a submitted case, please email specialstudy@fax.org, and the patient will be back on the patient data to be submitted section. If there's any errors on the patient data section, you should also email specialstudy@fax.org with the updates. And please include the special study IDs in communication. So study communication, we have our special study website here and also the Cancer Forum and Standards Resource Library. We will be posting all the webinars and all the announcements. So, and if you have any questions, please email specialstudy@fax.org. Study-related questions sent to personal fax accounts will be forwarded to the special study address. And you either need to send an email through the contact form of the website or email specialstudy@fax.org through your Outlook or your emails, your personal emails addresses. So please don't send both, as all emails go to the same account. We ask that you include FINs in all communication. So emails for the special study are being sent from the special study at fax.org email address through an outside server. The emails for the webinars might be sent through GoToWebinar, and you do not need to have an email for every webinar, as the same link can be used each time. If you have not been receiving these emails, send the following information to your IT department and ask them to put us on the whitelist. And we have the IP address listed here. So But if you haven't been receiving the GoToWebinar emails, that's okay. As long as you just use the same link every week, it should work. Here are the NCRA program recognition information slides. So these are all the webinars that we've had so far, and they're all worth 1 credit hour for NCRA, and all the numbers are listed. So the slides and the past webinars are available on our website and the Cancer Forum and the Standards Resource Library. So we have updated the instructions document, and it will be available on the study website. Questions from previous webinars and the Cancer Forum will be included on all webinars. We posted the frequently asked questions document on the website, the Cancer Forum, and the web forum. So now we will be reviewing frequently asked questions from the previous webinars. So for data collection, is the entire medical record needed or just the record of PSAs and scans? It might be easiest to ask for the entire medical record. However, only the records required to complete data collection are those that are asked on the web form. So only information during the surveillance period is required. What should be documented when a physician states a biochemical recurrence? We ask that you please mark this as the date of first recurrence by any method. So local, regional, and distant recurrences have specific definitions in the manual. And if the biochemical recurrence does not meet the definition of a local recurrence, please do not enter that under local recurrence or regional or distant recurrence. So what PSA level should be used to classify a patient as having a recurrence? We are not asking registrars to interpret the PSA results. So please record recurrence if the clinical notes indicate recurrence and if the patient receives treatment for recurrence. So if the physician only states that in the notes that the patient had a recurrence, that's the date you should use. But if the physician never states it and they start treatment, then the treatment date should be used. So does the patient have a recurrence if he was never disease-free after treatment? For the special study only, we are calling this that the never disease-free is the patient does have a recurrence. So we ask that you please record the date of the first PSA test after primary treatment as the date of recurrence. So never disease-free can be noted as progression of disease or persistent disease after treatment. What should PSA of 7.96 be coded as? We ask that you please follow the Ford's manual for this particular situation. The Ford's rounds PSA to 1 decimal point. So for example, 7.96 rounds to 8.0, and you should enter 80. The study directions state that normal testosterone levels are 250 to 1100 for nanograms per deciliter. So if you have a result in picograms per deciliter, this should be converted to nanograms per deciliter. So, and to do this, you should divide by 1,000. So, for example, 1,000 picograms per deciliter is 1 nanogram per deciliter. If the urologist and the PCP are retired or any of the providers, we would like you to please see if possible to collect the records from their offices. Often physicians might have retired, but the records are still available. So all NPIs are required for each provider that saw the patient during the surveillance period. If the NPI on the surveillance tab is unknown, then please enter 0 if there is no provider. Enter 9 if they have the provider, but the NPI is completely unknown. And enter 7 if it is unknown whether they have the provider. So comparing what information the NCDB tab has for a patient to what the medical record contains, there is more information available in the medical record than was initially abstracted. This is in the case for Gleason on prostatectomy and the date of last contact. So we ask that you please select no in order to update the information and fill in the most current data. And we ask that you use Board's manual version 2016 for the special study because it's the most up-to-date. So if there is a conflict in the MD stage versus the CTR collaborative stage and the clinical documentation that there was no regional nodes, what stage should be recorded? So this would be a discrepancy between what the physician states and what is the CTR collaborative stage manual should say. So usually a CT or MRI scan is done. If not, the nodes are seen on these scans, then you should enter CN0. And if no scan was done, enter CNX. Okay, and we can go back to the communication slide if people missed it. And I will start reading all the questions that we received today.
Eileen, if I can just chime in real quick.
Okay.
So, so again, thank you everybody for calling into the webinar and also for all of your help and work on this special study. Definitely, as the PI, the team here, we recognize the work you put into the special study, and so we thank you very much. Many of you probably received an email about some of the changes that were recently made, and I want to discuss that very quickly. So in the first few weeks of this study, there have been, based on the cases that have been entered, we have realized that there are a lot of ineligible cases, a lot more than expected, and we briefly discussed this last week on the webinar. And that's certainly concerning and affects the special study. And many sites have 12 cases that they're able to complete, but also many sites do not have 12 cases and may have a lot fewer than 12 cases, and sometimes because of the ineligibility. So, and because of that, and briefly mentioned last week, the decision was made and with a lot of consideration to loosen the eligibility criteria, which was described in the email that you received. And so the change, there were two changes. And I want to clarify this with everybody. One is that the first eligibility question, instead of having to have 5 years of records, we are just asking then for 3 years of records for the patient to be eligible. So that's a little bit loosened. And in addition, we are going to have cases that are in more recent years, even through 2010. And so hopefully with more recent cases, that would also make obtaining records easier. Now, the question that a lot of you will have is, does that affect cases you've already submitted or the cases that you're working on currently? The answer is no. These changes, if you already submitted cases, they already count. That you have credit for that. And the cases that you have currently that you're working on, this will also not affect that. Except for the fact that they only require 3 years of records for eligibility. The more recent cases for, up through 2010 are going to affect the cases that are being used for replacement. So you're already working on a certain number of cases. Those cases should not change. What should change, which you will not see right now, is the replacement cases. If you mark additional patients ineligible, the replacement cases you get to replace these cases will be more recent cases, I think from 2008 to 2010. And so I want to clarify that, one, we're losing eligibility a little bit. Two, the replacement cases will be more recent. And three, the cases you're working on are not affected, and the cases you're submitted already will not be affected. I also want to emphasize that we really did not make this change loosely. We really have put a lot of consideration to this, and we've made the changes to hopefully to make this special study a little bit easier than it has been. And so I hope everybody would be able to continue to help us with this special study, and just want to emphasize again how appreciative the team here is of your work on this. Thank you.
Okay, so Ron kind of addressed a lot of these questions, but I'll just read them just to reiterate. So we would like you to please finish the current cases that you have. The change of cases only affects the replacement queue. So your original list should not change, but if you mark patients ineligible, then those patients might be newer patients that you get on your list. So the cases that were previously submitted will remain on your list. We're just hoping that everyone can still get up to 12 patients. So the surveillance period remains the same. So we ask that you stop collecting data if the eight years is up, or if the patient develops distant recurrence or death, but whichever occurs first. So even if they develop a new primary diagnosis, we ask that you still continue to collect information until the patient develops distant recurrence or the 8 years is up from the surveillance period. So if you submit a case as ineligible, then it should not be on your screen anymore, and it would be a new one would pop up.
Eileen, there is a question to see if you can go to the slide about the NCRA CE information.
Yes. So if the patient passes all of the 3 screening eligibility questions and you are able to complete the web form, then the patient is eligible. So these changes will go into effect at 11:59 p.m. Central Standard Time today. So they won't be on your list right now, and it will only be if you mark a case ineligible after midnight tonight, Central Time, then you will receive additional patients on your that are more recent. So bladder scans for residual do not need to be added to scans. Only the scans for purposes of detecting prostate cancer or recurrence anywhere in the body need to be entered. So if the surgical pathology report does not state LVI or perineural invasion, please confirm that you should answer no or unknown. So if the surgical pathology does not mention LVI or perineural invasion, then you should enter unknown. I guess that the slide that we had discussed had something slightly different than your question that was answered on the Kent forum. So if the original treatment NPI has retired and they have someone new, if the NPI number that we want is the one that for the physician that treated the patient. And we would like you, if the patient has more than one type of primary care doctor, for example, then please enter both if you have that available. And if you do not have both, please enter the NPI that you do have. If you have not submitted anything yet, then you will not be getting all new cases. Only if you mark a patient ineligible now will the replacement patients will change. So on the eligibility criteria questions, now that we have decreased it to 3 years, so that's still only for eligibility, so you have to have at least 3 years of records for the patient to be eligible, but the surveillance period is still 8 years of data. We have extended the deadline to August 28th. So if you have less than 12 cases in your facility, you will get more replacement cases up until you are able to complete 12 eligible submitted cases. But if your facility doesn't have enough cases for replacement, it is possible you still might not be able to get 12. If you already completed and submitted all of your cases, regardless of whether the number was less than 12, you will not receive any more cases. If you need to make changes to a patient that you already submitted, just email specialstudy@fax.org, and we can put this back on the section for the patient's data to be submitted. So sites that have already submitted all of their cases and completed the study will not be affected. If there is an error message for hormone therapy as part of first course treatment, which should be none, should you leave blank or enter 999? Please follow what's written in the instructions manual. So for the web form on the additional clinical information page, this should be 999. So if the patient has at least 3 years of medical records available, then the patient is eligible. For eligible patients, please enter as much data as you have, but stop at 8 years.
Eileen, can you go to the slide where we talk about a PSA recurrence that is not local?
Sure.
So
this
the
one?
PSA recurrence. No, there's one that where we say a patient may have a biochemical recurrence, but doesn't. There we go.
Oh.
No. So I'll just address this verbally. So there are a few questions today about if a patient has an elevated PSA, which is a recurrence, and the doctor's note says that there is a recurrence, but that may not be necessarily a local recurrence. So, and I know we've gotten a few questions like this before. So a patient could have a PSA-only recurrence that's stated on the doctor's note, but if the patient, for a patient to be scored as having a local recurrence, that has to meet the definition that is in the manual, which is by a biopsy or imaging that shows local recurrence. So it is definitely possible that a patient may have a recurrence because of PSA only, and that patient may not have a local recurrence by definition in the manual, may not have a regional recurrence by definition in the manual, or may not have a distant recurrence by definition in the manual. In fact, that could be very common. And so it is okay for the patient to have a recurrence that is entered on the web form. It's okay for the patient to have a recurrence, but you say no for local, no for regional, no for distant if the patient doesn't meet definition for local, regional, or distant. That may actually be a pretty common situation.
So you do not need to keep any of the records after you are done entering them for us. If you already submitted 10 cases and nothing new is added tomorrow, then can you assume you are done? Yes, that is correct. So you can either submit all your cases at once or at one by one, but it might be easier to just submit them all at the end in case you need to make changes to previous ones instead of asking us to reset them for you through email. So for the recurrence in the PSA section, are the only options local, regional, or distant? But that's correct, but there's also a date of first recurrence detection by any method. So that is the only place in the web form where you would enter a biochemical recurrence if the physician states that the patient had a biochemical recurrence. So an elevated PSA does not technically mean a recurrence. The physician has to state the recurrence. So our plan is that the replacement queue will be added by tomorrow as a one-time situation.
Eileen, there is a question that I just wanted to sort of discuss. So there is a question on the web form that asks about how many cores on pathology, and there's some pathology forms where this information may be missing. And we would usually, based on the manual, we would say that if the number of cores is missing, the number should be entered as 999. But the registrar is saying that 999 doesn't work on the form. It's giving an error. This is something that I think we'll have to check into today to see if it's programmed correctly to accept 999.
Okay, maybe she can just send an email to specialstudy@fax.org and the head can look into it. So here is a scenario where 12 cases are on the list and 3 were ineligible with no replacement patients. So the remaining 9 have been submitted, so this facility will not get new patients with the changes at midnight, and that's correct. And then there's another scenario where 12 patients were on the list, 3 were marked ineligible, and the remaining 9 have not been submitted. So those cases would get 3 additional patients on their list since they are not finished with the study yet.
Eileen, for the previous question about 999, the number of cores, and the 999 giving an error, I want to thank another registrar which encountered the same issue and has posted her solution, which seems to work. So thank you for that.
So the tip to that 999 issue that someone said was that if you go to another tab and then come back to the data element with the red box, it would then allow you to enter the 999 and move on. So just so everyone's aware, we're still having the webinar, but all the questions have been verbally answered, and if not, um, so we'll still be here to answer for 10 more minutes. So if anyone has more questions, you can continue to type them on the webinar. So if the last 12 cases that were sent were submitted as ineligible, um, if you didn't get any replacements, then you will, and you submitted all your cases as ineligible, then nothing else will be done and no new cases will be sent. So if you have not submitted a patient yet and you're wondering how much time it takes to complete the web form for each patient, this the time for each patient varies. Most of the time is spent collecting all of the records, and that time depends on the institution. Some people have to contact outside institutions, and others have everything in an EMR. So the time on each patient really varies on the patient and the institution. Yes, so the study has been extended to August 28th. So the case submission process, um, once you enter information on a case and you're ready to submit, it's really up to the registrar on your preference if you want to submit a case once you're done with each patient or wait to submit until you're done with all of the patients. So what we recommended was that you would wait till the end to submit all your patients, but it's really up to you. The only reason we made that recommendation is because we had been getting some emails where registrars had submitted patients and they needed to make changes. So um, just to save time in case you need to make edits to a submitted patient, that's why we said to just wait till the end to submit them all. So the ICD codes should be what you use for the cancer registry. and the ICD code should be the same as what you would use for the NCDB. Okay, everybody, I think it's 12 o'clock now, so we will see you all next week, and thank you so much for all your hard work on the study.